Hello and welcome back to Pharmacology with Dr. Sokolow. And this is another module on the autonomic nervous system. And more specifically on this one, we are really going to talk about the agents that are used to target the autonomic nervous system and to target either the nicotinic receptor or the muscarinic receptors for the cholinergic nervous system specifically. So first, let's talk about cholinergic drugs. So you remember cholinergic refer to acetylcholine. This is the natural neurotransmitter. And there are two types of receptors, the muscarinic receptor and the nicotinic receptor. So we are first going to talk about drugs that are going to bind to the muscarinic receptor. So what are those drugs? They are called cholinergic drug or direct cholinomimetic. Mimetic, that means mimics the effect of acetylcholine. And so these drugs are going to enhance the transmission at cholinergic synapses. And again, you have to know what acetylcholine do on each specific organ, and then you will know what a cholinomimetic drug is. So a cholinomimetic, of course, acetylcholine, because this is the endogenous neurotransmitter, would be useful, but the problem is that it has a very short duration of action, so it's really hard to be used, for any clinical indication. The muscarinic agonist, muscarine was the pharmacological agent that was used to discover those muscarinic receptors, and they were extracted from a mushroom. In terms of drugs that are used, for clinical purposes, and that's what you are interested in, and that's what you're going to have to make a list of those drugs when you study. So the first drug that is a muscarinic agonist is beta-nickel. And this one is used for people with urinary retention. This is not a common condition, or actually it's more common in maternity. So women after delivery, sometimes it takes time for them to recover from labor, and then they cannot pass urine after giving birth. So this is something that can be given, and it's used for the treatment of urinary retention. And so I have this little balloon to kind of explain why it works. So if you remember from the last module, I said that acetylcholine works by contracting the detrusor muscle. So the detrusor muscle is the muscle that allow the contraction of the bladder, and then acetylcholine actually relax the sphincter. So that means open this little sphincter, and so then the urine can be released. So a muscarinic agent will actually help with the contraction of the bladder. So you see, then we'll squeeze in, and then the sphincter will open, and that's how the urine will be passed. So this is muscarinic agent, and this is beta-nickel. Because the drug is not really selective to only the receptor on the bladder, it can also activate the receptor on the GI tract, and then therefore it will also cause increase of GI motility, because if you remember, cholinergic system, rest and digest. So this drug will just mimic the effect of acetylcholine. Now, pilocarpine is a drug that is used in ophthalmology, and it's used for the treatment of glaucoma. The way it works, it just contracts the iris sphincter muscle, and then will facilitate the outflow of the aqueous humor, and therefore release the intraocular pressure. So that's how pilocarpine works. It's also a muscarinic agonist. So these two drugs are the one that you're going to have to add to your list of muscarinic agonists. Now we're going to talk about anticholinergic. So that means they are going to have the opposite effect of the effect of cholinergic, or the effect of acetylcholine. So the anticholinergic drug, we're going to first talk about muscarinic antagonists, because again, you can have a drug that bind to the nicotinic receptor or drug that bind to the muscarinic receptor. So let's talk first about the muscarinic antagonist. And if you remember, the muscarinic receptor are on the post-ganglionic neuron, and so therefore they're going to be on the organ that are innervated by the postganglionic neuron. Here are some agents that you have to know: atropine, scopolamine, ipratropium bromide, and tolteridine. The other one are drugs that act on the central nervous system, and I'm not going to ask you to remember them now. You'll learn them next quarter when we talk about central nervous system. But what you have to know is like the indication of those anticholinergic drugs, those muscarinic antagonists. So atropine, we'll see on the next slide. This is used in ophthalmology and also to treat bradyarrhythmia. Scopolamine, for those who have motion sickness, you may have used scopolamine. So it's a patch that you put behind your ear, and it will just prevent motion sickness. Ipratropium bromide, it's used for the treatment of COPD. In this module, we are not going to go into detail about this drug, but once we talk about respiratory pharmacology, we'll go more into detail of indication adverse effects. For now, what I want you to know is to focus on which receptor they are acting. So in that case, they are acting on the muscarinic receptor and they are an antagonist. So ipratropium bromide is used for the treatment of COPD. Tolteridine is used for the treatment of incontinence or overactive bladder. And then the other one, you don't have to know the name, but you have to know that some of these drugs can be used for the treatment of peptic ulcer. And again, this is a drug that will be also covered next quarter when we talk about GI system, and can be used for the treatment of Parkinson's disease. So all the indication, you have to know them, but I'm only asking you to focus on the drugs with the asterisk. Here, big red star. This is a very important slide again about the anticholinergic adverse effect, because every time we're going to talk about an anticholinergic drug, whether it is in respiratory lecture or next quarter in the CNS lecture, I will refer to the anticholinergic effect. And so if you know it now, I'm hoping that you will remember also in a week, 2 weeks, a month, and later. So because it has the opposite effect of acetylcholine, which acetylcholine we said is rest and digest, here it's going to be the opposite effect. So that's going to be constipation. And then dry mouth, because also if you remember from the slide where I showed innervation of the sweat gland, and acetylcholine activate the secretion, the saliva. So if you have an anticholinergic drug, it is going to prevent the secretion, and that's why you have that dry mouth as an adverse effect. How can you alleviate that? By drinking a lot of fluid. And then there's also like some sugar-free gum that can be given, especially elderly patients. Usually elderly patients are the ones who are getting anticholinergic medication. And to prevent that, we can give them like those sugar-free gum just to stimulate their salivary glands. And then there's also like some dry mouth gum that can be used. Treating the mouth with a saliva substitute, such as biotin gel or Salivert, and using an alcohol-free mouthwash, because also like the alcohol can also like dry the mouth. Another adverse effect is blurred vision, because again, remember the effect of acetylcholine is like the accommodation of the near vision. So if you give an anticholinergic, they're going to have a problem with that accommodation of the near vision. And patients also who are hospitalized and receive anticholinergic drug to prevent that effect is just to tame the light in the room. So that's going to help them with that adverse effect. And then urinary retention, because it's the opposite effect as I just showed with the cholinergic drug, the muscarinic agonist. Here you're going to have the opposite effect. Is like on your bladder. Maybe I'm going to have this. So instead of contracting, you're not going to have a contraction and you're not going to have a relaxation of the sphincter. And so therefore, you're going to have the opposite effect and you're going to have urinary retention. This can be minimized by asking the patient to avoid urine or, to pass urine just prior to giving the medication. So then they will not have an issue after they take the medication. Now, the first anticholinergic drug that we're going to go in more detail. So in this module in particular, atropine. So atropine, it's an anticholinergic drug that blocks the muscarinic receptor. Very used in acute care setting. And also there is another use that for the management of poisoning by poisonous mushroom. I don't think here in California you would see this. It would be more in the region where it rains a lot, or like in Belgium where I'm from. A lot of people go to the wood and get mushroom, and if they don't know what they are, they will collect mushroom and think that they are edible, and if they are not, they can have poisoning, and you can use atropine as an atropine to reverse that. And also the nerve gas agent that were used not long ago in Syria war, and so military will carry a atropine, not an EpiPen, but an atropine in countries where they use chemical weapon just to prevent death by those chemicals that can cause, like respiratory distress and, massive release of acetylcholine. It's also, so as I said, widely used in acute care settings. So IV atropine is used as an adjunct to pre-anesthesia to prevent bradycardia occurring during certain procedures. So you will see that it will be an adjuvant prior to the anesthesia to make sure that the patient doesn't go into bradycardia. And it can be used IV, in code blue situation when you have a patient that is coming with a acute symptomatic bradycardia. So this main indication in clinical setting. Then, as I said, they can be used for poisoning. And then also it can be used in ophthalmology. I don't know if any of you had dilation of the eyes in the eye doctor. And so basically that's what they use. They use atropine eye drops just to dilate the eye. And atropine, so in the ancient time, in the Roman time, ladies, they were called the atropa belladonna because they were using atropine to dilate their eyes and look, prettier. So that's the effect of an anticholinergic drug on the pupil to induce like a dilation of the pupil. Now, antimuscarinic agent can be used for the treatment of overactive bladder. So that's what I just showed with my little balloon. And so there are, like, if you remember also from a slide from the last module, I said there are different subtype of muscarinic receptor. So antimuscarinic most of the time are going to bind to, different type of muscarinic receptors and are going to have, more adverse effect. But now there are like some more selective drugs that are M3 receptor selective. And those M3 receptors, you see they are located on the bladder diffuser muscle. So If you have an antimuscarinic agent, so you have the non-selective that block M2 and 3, that's the case of tolterodine. So again, relax the detrusor muscle, and so then you'll have a relaxation of that overactive bladder. And then you have M3 selective that will only, or mostly block the M3 receptors like oxybutynin, solifenacin, darifenacin. So again, I'm putting those stars because you have to know those names. And again, here, what you have to know is like which type of receptor they are blocking, whether they are selective or non-selective, what their indication, overactive bladder. And then adverse effect, again, refers to the general, adverse effect of the anticholinergic. But in this case, what you see mainly is going to be GI adverse effect and xerostomia, which is the dry mouth that I explained in one of the previous slides. Now let's move on to the cholinergic agent, and particularly nicotine. So we talk about muscarinic, agonist, antagonist that bind to muscarinic receptors. We have cholinergic agent, the one that bind to the nicotinic receptor, and the most known one is nicotine because that's how those receptors were discovered. And you all know what nicotine is. This is the natural liquid alkaloid found in tobacco leaves, and tobacco contains 1 to 2% of nicotine, and one cigarette delivers 1 milligram. So 60 milligrams can be fatal in adults, but even a heavy smoker is not going to smoke like 60 cigarettes at once. So it's unlikely that they are going to die from a acute poisoning. What they are dying for are from the long-term use of cigarette smoking and the chronic disease associated with cigarette smoking. Mechanism of action of nicotine depend on the dosage, because you have nicotinic receptor on the parasympathetic or autonomic nervous system, but also in the sympathetic parasympathetic nervous system, but also in the central nervous system. On low dose, which is the dose that you get with cigarette smoking, nicotine activates the nicotinic receptor. But at high dose, on the other hand, is just inhibit the nicotinic receptor, and this at several sites. Autonomic ganglia. Remember, those nicotinic receptors are on all the presynaptic, preganglionic receptors, and also on the postganglionic receptors. And and on the receptor of the neuromuscular junction. So they are going to be on the autonomic ganglia, the adrenal medulla, the carotid, aortic arch, and central nervous system. And so that's what I was saying here. You see acetylcholine on all the ganglia. These are the nicotinic receptor, neuromuscular junction. That's why actually it can cause tremor, like people who are smoking, you can see them shaking. And oops, what's going on here? So of course you have the cardiovascular effects of that are caused by low dose of nicotine in cigarette smoking, that result from the activation of the nicotinic receptor in the ganglia, because you see you don't have postganglionic receptor on the heart, but you have them on the preganglionic neuron, therefore on the ganglia. And then they can stimulate the secretion of epinephrine from the adrenal medulla. So that's why you're going to elicit a discharge of epinephrine from the adrenal medulla, which cause a vasoconstriction, increase the blood pressure, also increase the heart rate. And these are the effects that underlie the cardiovascular death in smokers. Now, also have some effect on the GI tract, which result from the activation of the nicotinic receptor in the ganglia. So on those receptors here, and then that also gonna stimulate, you know, the release of acetylcholine on the GI organs, and that will cause an increase of GI tone, rest and digest, and can cause, in some people, you know, they have nausea or vomiting. Then CNS effect, it's a stimulant, so this might be a good thing, but you have all the bad things associated too. So I think the harm versus the benefit here, it's pretty clear that you don't want to use that as a CNS stimulant to learn your pharm faster, because the effect is actually stimulate and facilitate memory. And they also suppress appetite. So that's why people who stop smoking usually can gain weight, is because they don't have that effect on appetite suppression. Can cause also moderate tremor, and at high dose, some people, it can cause convulsion, not from smoking, but more from exposure to too much nicotine. Now, how can you help people who are smoking? There are several drugs that can be used for smoking cessation. The oldest ones are the nicotine-based product, and there are like various forms of them. You have the patch, the gum, nasal spray. They come in different brand names. You don't need to know the brand name, but you need to know that they are nicotine-based product. And because it's a substitute to nicotine in the cigarette, the advantage is that you can start with a high dose of nicotine. You know, if it's a patch that they applied, you can start with a 21 milligram. And then after 2 weeks, you can taper down to 14 milligram. And then if they are doing good with 14 milligram, then you taper down to 7 milligram a day. So every day they have to change their patch. And then ultimately they will lose that dependence from nicotine. Now there are newer agents such as varenicline and bupropion. So varenicline, it's or you know, Chantix, but again, I'm not asking you to learn the brand name. If you know it, it's fine, but essentially you need to know the generic name. So varenicline, it's a partial agonist. So if you remember from the lecture on agonist and antagonist, the partial agonist has some intrinsic activity, but it will also have an antagonist effect. So it's going to block the receptor from nicotine. So it's going to prevent nicotine to bind on those receptors, and also has an intrinsic activity. So it's going to have, you know, provide some pleasure, but at the same time, you're going to bind the receptors, and then it's going to reduce the craving and decrease the pleasurable effect of cigarette and other tobacco products. So, and then bupropion, which is Zyban, this one is an atypical antidepressant, which we'll learn in more detail next quarter. This one, we don't know its mechanism of action in terms of smoking cessation, but it has been shown and approved by the FDA for that indication. But the studies have shown that varenicline is more effective than bupropion for both inducing smoking cessation and preventing smoking. And this is it for this module. I hope you enjoyed this video, and we'll see you in the next module.